The NHS has released its priorities and operational planning guidance for 2021 to 2022. The headline feature of it is changing the way that the NHS in England plans to go about structuring its referrals to enable integrated care systems, or ICSs. The NHS's intended aims for this are improving outcomes in population health and healthcare, tackling inequalities in outcomes, experiences and access, enhancing productivity and value for money, and helping the NHS to support broader social and economic development. At a local level, CCG functions will be subsumed into the ICS NHS body and direct commissioning functions will be transferred or delegated to ICSs. The major change that you will feel in the short term is you'll be asked to direct referrals to HES instead of via GPs. This will be implemented by the use of electronic eye care referrals, or EeRS, where procured. The intention is to allow you to send referrals and large image files between primary care optometry and the hospital eye services. The aim of this service is to overcome the barriers to consistent commissioning of extended primary eye care services. There are a few other things included in the proposal for eye care, such as implementation of digitally supported services such as video consultations, and the creation of a digital diagnostic hub. To find out more, I spoke with Loxu Optical leads Nid Sabir and Zoe Richmond about the upcoming changes.
Do you think that this will improve things? I guess the phrase postcode lottery rarely has any positive connotations. So if we move towards a more nationwide commissioning model, hopefully, do you think outcomes will get better?
I think so. I think there's an opportunity because at the moment we're working across so many borders. Patients don't recognise those borders, and I think if we scale up to a more standardised commissioning model, recognise that patients ought to be able to present where they choose to and break down these borders, I think it can only be an improvement.
It does seem like tele-optometry is here to stay. I think that's one of the key things that I got from it, that a tele-optometry triage system will be a big part of what's coming in the future.
Yeah, I think you're absolutely right. So I think triage is going to be a huge element of all care. Within queues, we introduced this concept of directing the patient to the most appropriate practice and practitioner across a network of optical practices. So I think that concept would remain going forward. And similarly, in a hospital eye service, certainly around urgent eye care, there would be an expectation that patients would be redirected out to primary care where it's appropriate to do so. Hospitals and trusts are invited to look and see which patients will be suited for patient-initiated follow-up, that sort of thing. That follow-up appointment, that follow-up assessment could be appropriately delivered in primary care, not an automatic follow-up in the hospital eye services.
There was, again, I remember in the past the difficulty of getting an NHS Net email account, and with this system it does sound like things are going to be a bit easier.
It's what primary care have needed and should have had, years ago. We are not connected to the NHS as we ought to be. So access to the patient summary care record, the ability to refer electronically, and receive feedback, direct referral and feedback to the optometrist recognised as the referrer will be a huge step forward. But it needs to be so much more than that as well. We need to be able to share clinical data, images, that sort of thing to support advice and guidance, and so that we can really broaden the scope of care that's delivered in primary care. And the EeRS should be the enabler to allow for that.
The big three things I saw from this was, which we've always talked about, but we've got starting to now see it galvanise, is utilising our workforce better, ultimately being able to refer in an appropriate manner and being able to directly refer. Secondly, giving that feedback, and that feedback loop for allowing the patient, the practitioner to learn from it. And fourthly, I think one of the big things during COVID was advice and guidance. Before I refer on, can I actually do a video call and speak to my consultant on the other side and see what he or she may want me to do with that patient? And that's an element that we've not really had. If we have had it, we've not really utilised it, but we tend to utilise it because our back's been against the wall. So we thought, right, I don't want to put this patient in a situation where they may be at risk of getting COVID in a setting or inappropriately refer them. So let me speak to someone. And I think that's where the work is really going to be, and that they're the opportunities for communication.
There is talk about reallocating clinical cost elsewhere. I think that's an important point to point out, that there may be major changes around the corner because they want to try and maximise value.
All systems are having to work, in a very difficult time, and they do need to identify those areas that, to use somebody else's words, we could afford to stop doing clinically. So clinically, they're considered low risk, and but in stopping doing it, then you can reallocate the capacity to those patients that are more at risk of immediate sight loss. And that's going to be very difficult for clinicians to have those conversations. But we know through COVID that there's an opportunity to deliver some care in a different way. So we can deliver care remotely, and that has a tendency to speed things up and make systems more productive. So that's one opportunity. The other opportunity is to not routinely offer a follow-up assessment, but to leave it to the patient. So that's what they talk about in terms of the patient-initiated follow-ups. And certainly one of the areas that they're looking at in the eye care pathway is the post-operative cataract assessment. Now, the Getting It Right First Time report, published before COVID, actually clearly states that we ought to move the low complexity cases out into primary care. Now systems are looking at that again and saying, well, actually, does anybody need to perform a clinical assessment on these patients? Obviously, there's going to be need for a refraction and that sort of thing, but there are difficult questions being asked of clinicians and commissioners at the moment to make sure that those patients most at risk of sight loss are able to be seen in a timely manner.
I spoke to my colleague about this particular change, and she just sighed because of the concept of having to deal with another body, and I fear that may be other people's reactions.
It's coming whatever. So my attitude is always, we need to find the positives in it and influence them, and do the best we can with them. So that's where I am with it.